spinal cord. We know this protein is essential for lower motor neuron function, which these are located in the brain and spinal cord. And if this protein is absent, the lower motor neurons eventually will degenerate and die off with time. SMN2 is very similar to SMN1, except that it lacks one specific region of the gene. And so in that regard, it only encodes about 10 to 20% functional SMN protein. So of course, the more copies of the SMN2 gene that someone has, the more functional SMN protein they're going to make. Both of these genes are located on chromosome 5, and they're right next to each other. So I think this picture is kind of helpful in understanding the etiology of the disease. So in the blue here, we have the SMN1 protein, or the SMN1 gene, excuse me, which, as you can see, 100% of this protein product is a full-length SMN protein. The SMN2 gene is in yellow here, and it lacks exon 7, which is why it encodes a less stable protein. So about 80 to 90% of the protein that's made is truncated, and it's degraded and recycled by the cell, whereas about 10 to 20% is functional protein that can be used by the lower motor neurons. So the SMN1 gene is the primary disease-causing gene, and most people with SMA will have a deletion of both copies of this gene on chromosome 5. Now, about 2 to 5% of people will have a deletion on one copy of the gene, and then on the opposite copy of chromosome 5, there will be another change in the gene that knocks out this protein's function, and that can be a mutation within the letters of DNA or some other change that disrupts the way that this gene makes the protein in the body. And then the SMN2 gene is the disease modifier gene. So I mentioned that people can have variable copy number of this gene. Most people will have 1 to 2 copies of SMN2, but anywhere from 0 to 5 copies has been seen. And typically 3 or more copies of SMN2 is associated with a milder clinical presentation of SMA. So historically, we classified the type of SMA based on when a child started having symptoms and then their maximum gross motor milestone achieved, whether that be rolling, sitting, walking, how far they could walk. And it was helpful for being able to give parents an idea of prognosis, how the child would do long term, and then also from a management standpoint. And we've sort of seen this change clinically as we're actually diagnosing kids based on their gene status on newborn screening much earlier than they would have even presented with symptoms. So in that regard, we're actually, I think, using the SMN2 gene information more now to give at least parents a little bit of insight into what the future might look like. And this next table here, I think, is helpful in kind of showing that. So on the left-hand side here is the SMN copy number, and then how that translates into the clinical phenotype. So most people with 1 or 2 copies of SMN2 are going to have SMA type 1. If a child has 3 copies of SMN2, they're most likely to have SMA type 2, but about a third have type 3 or type 4. And then if there's 4 or more copies of SMN2 present, most of these individuals will have SMA type 3 or type 4. So again, it's not a direct correlation, but it is at least helpful in giving some insight into the future. And we know that obviously there's variability in copy number and even between, members of the same family who have the same SMN2 copy number, they can have variability in their disease severity. So that just tells us that there's other modifiers. These are just 2 of our 23,000 genes, and there's probably other things that also play into a child's disease severity. So as far as making the diagnosis, genetic testing is considered the standard now for determining if a child has SMA. Again, all affected individuals are going to have 2 non-working copies of SMN1 and then variable SMN2 copy number. And now that we have instituted newborn screening for SMA in over half of states across the US, this is leading to early diagnosis in many, many individuals. Of course, there's some situations if newborn screening is not available in that state, or if there's a false negative on newborn screen, that could lead to a delayed diagnosis. So it's my understanding that most states are looking for a deletion on both copies of chromosome 5. So in theory, we would miss about 2 to 5% of kids who don't have a deletion on that second copy, but have some other change in the DNA. And then again, if they have a more of a mild presentation, they're not screened via newborn screen, the diagnosis may take a little bit longer. But eventually, most kids get diagnosed based on genetic testing at this point. So as far as our algorithm for genetic testing, most clinicians are going to start with deletion duplication analysis of the SMN1 gene. If there's 0 copies of this gene, then we can, of course, confirm the diagnosis. And again, if there's only 1 copy present, we can look for that second disease-causing change, and then that would confirm the diagnosis. If we don't identify any second change in the second copy of the SMN1 gene, then at that point, we would consider other diagnoses that could look very similar to SMA, but maybe less common in the population. There are several infantile hypotonia genetic testing panels out there that will include SMA and other diseases that present very similar in infancy with, low muscle tone, respiratory distress, that type of thing. And then again, if we make a diagnosis, we typically want to also include looking at SMN2 copy number, not only for clinical correlation, but a lot of the different treatment therapies out there are now requiring this for insurance approval. And I've actually seen this in adult neurology the last few years, where these individuals have lived with SMA for many, many years. They may have undergone genetic testing 20 years ago, and at that point, the technology to look at SMN2 copy number wasn't even available. So we've had to go back and retest them just to determine their SMN2 status so that we can then apply for insurance approval of the different therapeutic treatments that are now available. So that's been kind of an interesting phenomenon, is looking at, how these individuals were diagnosed clinically and then going back and looking at their SMN2 copy number retrospectively. This next slide again kind of just depicts what I just went over, but I thought it might be helpful to see it in this sort of format. So again, either we have a clinical suspicion of SMA, or a child's picked up on newborn screening when there wasn't necessarily a suspicion, but the diagnosis was made that way. So we proceed with SMN1 deletion testing. And if we see that there's 0 copies of SMN1, we can confirm the diagnosis. If there's 1 copy of SMN1, we can proceed with sequencing the second copy of this gene. And if we find a mutation there, then we can again confirm the diagnosis. And then in cases where there's 2 copies of SMN1 present, and we would consider still sequencing the gene, is when there's a blood relationship between parents, and the term we use for that is consanguinity, where it's possible that both parents could carry a disease-causing mutation within the SMN1 gene that would not have been picked up with deletion duplication analysis. And in this situation, if there's a mutation in both copies, then again, we can confirm diagnosis. Or if there's no mutation present, then we can think about other disorders at that point. And again, looking at SMN2 copy number, not only for predicting clinical severity, but also then being able to allow children to immediately participate in therapies that could be beneficial to them long term. So as far as newborn screening, it was actually recommended that newborn screening be instituted across the US in June of 2018. And currently, as of August of this year, it was included in 32 states as part of their newborn screening. So we've made some progress in 2 years, which is wonderful to see. And the reason that it was recommended that we include this disorder on newborn screening is because of the progress that we've made with treating this disorder. So we know that children with SMA, and especially in SMA type 1, have irreversible loss of motor neurons within the first few months of life, possibly before they're even symptomatic. And so if we can diagnose these children much earlier, we can then initiate treatment. And that not only helps their long-term prognosis, but it also avoids the diagnostic odyssey for families. So as we've improved our turnaround times for genetic testing and our turnaround times for initiating treatment, it's, parents are not having to wait weeks or a month to get a diagnosis. They can get a diagnosis immediately, and we can start treatment much sooner. So as far as newborn screening, the way that it works is that they use real-time, what we call PCR, or polymerase chain reaction, that actually amplifies that specific region on chromosome 5 where both genes are located. And we can look for that deletion of the SMN1 gene. So some states will also look at SMN2 copy number on the dried blood spots, if possible, if they have enough blood to be able to gain that information. But either way, if the diagnosis is made or suspected based on newborn screening results, then the recommendation is that we follow up with molecular testing in order to confirm diagnosis and also provide more specific or accurate information regarding type 1 and type 2 copy numbers. So this is a picture of which states are currently screening for SMA. This is from the curesma.org website. And currently, like I mentioned, 32 states are screening, which equates to about 68% of newborns that are born in the US will be screened for SMA. And it's my understanding that a lot of these states that are still gray and not yet screening are working towards that. So we're getting to the point where we will hopefully be screening across the entire country for this disorder. I also mentioned that we've improved our genetic testing strategy. And so I think some barriers in the past to genetic testing have been cost, insurance coverage, and then also just the time that it takes to get results back. And so there are some sponsored testing programs out there now that allow people to get tested for SMA, and it's much more cost effective, and it's also a lot quicker as far as results turnaround. The program that I'm most familiar with is Invitae Genetics, and they offer a program called SMA Identified, which is sponsored by Biogen, and it's done at no cost. And the goal of this program is to facilitate access to genetic testing to help diagnose SMA or carrier status. And so they offer 3 different panels. The first is their just standard SMA panel, where they look at SMN1 copy number first, followed by sequencing of the gene if they need to, and then SMN2 copy number as well, which is done in just a few weeks' time. They also have carrier screening, which just looks at SMN1 copy number, also done in a few weeks. And then they have their STAT panel. So we've used this for children who have come back positive on newborn screen, and we're trying to get this information as quick as possible. And we can look at their SMN1 and 2 copy number, and we get results back within 4 days, which is obviously really, really helpful for initiating treatment sooner rather than later. The SMA Identified program eligibility, I think we can usually get most people to fall in one of these categories. So either they are suspected of having SMA, or they've been diagnosed but they don't know their SMN2 copy number, which is where I've used this program in adult neurology to determine SMN2 copy number in people who've been diagnosed for many years, but we just don't have this second piece of information. Also, if they are not diagnosed but have a family history or a first-degree relative with SMA, this program is available to them. and then anyone who is either considering getting pregnant, already pregnant, or just want to know their carrier status. So like I said, we can usually get most people to fit in one of these categories, which has been wonderful for being able to offer free testing to them. And also, we're able to do the testing on saliva via Invitae. So that's also been a nice perk, is that we can just mail saliva kits to patients' homes. They're able to do the testing in their own home, ship it back, and then, like I said, we get an answer anywhere from 4 days to just within a few weeks' time. So the last thing that I wanted to talk about was SMA inheritance and recurrence. As I'm sure most families with SMA are aware of, this is an autosomal recessive condition. So we see a change in both copies of the gene on opposite chromosome 5s. Most of the time, parents don't know they're carriers. The only way they would know that is if there's a family history of the disease, or perhaps they underwent carrier screening prior to conception. If you have one working copy of the SMN1 gene, then you don't have any clinical symptoms. So there's really no way clinically to know that you're a carrier of this disorder. The prevalence in the US is about 1 in 6,000 to 10,000 live births. And we do see that all racial and ethnic groups are affected, but it does vary from group to group. So it is primarily a Caucasian disease. The estimated carrier frequency is the highest among Northern European Caucasians at about 1 in 45 individuals. But this chart here to the right shows individuals, race or ethnicity, and then the likelihood of them to be a carrier of this disorder. And about 2% of people who are affected, they will have one parent who is a carrier, and then the second change in chromosome 5 will occur de novo or new. So we know that genetic conditions have to start somewhere. It's not unexpected that a person could have a new change in that gene that was not inherited from the parent. And because that is a possibility, we do recommend confirming that both parents are carriers of SMA, because if only one is a carrier and the second change occurred de novo, then that would obviously change recurrence risk for parents if they are thinking about, family planning and future pregnancies. That would be something to consider in these cases. And then lastly, here's my contact information. I'm happy to be a resource to anybody who has questions. Please feel free to reach out via email or phone if I can do that for you. And with that, I can take any questions that you guys have.
Thank you, Katelyn. I know this touches on your last slide that you just presented, but earlier in the day we had a question from an attendee, and I know Dr. Lakota had talked about it, and I said, well, we can talk about it again later too when Katelyn hops on. But like I said, I think you might have answered it, but just to reiterate, this person said that his fiance and I would like to try and have a baby, and she's combination type 1 and 2 SMA. Mm-hmm. And his family has no known SMA conditions. And so he's curious if he should participate in a genetic test.
If he undergoes carrier screening and he's not a carrier, then that would I think be helpful information to them. So she has type 1 in between type 1 and type 2?
Yes.
Okay. So she would automatically pass on a non-working copy of the gene to a child. So then really his carrier status is what would come into play as far as are they at risk to have an affected child or not. Okay. So if he's not a carrier and he has 2 working copies of the SMN1 gene, then their children would not be at risk to be affected.
Okay. Well, I hope that helps. If that person has any other questions, feel free to send me a note in the question screen. Other than that, we did not get anything, Katelyn. So thank you for your time. That was really, I thought that was really thorough presentation, and I learned a lot. So thank you.
You're welcome. Thank you for having me.
All right. Have a good rest of your Saturday.
Okay. You too. Thank you.